So first of all, just a little bit about us. So we're from Nottingham Radiotherapy Centre in the East Midlands in the UK. We have 6 LINACs altogether, so 2 of those LINACs have exact track dynamic with 6 degrees of freedom capability, with a third being commissioned hopefully in January, all being well. We have 2 LINACs at the moment with a line RT, again with a third hopefully being commissioned on another machine around March time. We use Align RT to treat both our adult and paediatric patients at the moment. Our Align RT journey started with our breast patients. We started with both free breathe and our DIBH patients.
It's just a little bit about our paediatric service. So we have 2 paediatric clinical oncologists, 2 therapeutic radiographers, one of which is me, and obviously with the opening of the UK proton centres, our workload has significantly reduced, which tends to be now more palliative patients as well, which can be upsetting for the staff and for the patients, obviously. But we still do treat quite a lot of our patients radically, particularly if they're non-eligible for protons, so if they're highly metastatic, or we do have quite a few families that just prefer to stay put if family have like work, life, commitments. It's not that easy for them to travel, so that can be up to them. And we also join forces with the Birmingham service. So with the proton centres, obviously with our reduced workload, we could struggle to keep our service up and running. So it was a good way of making sure that our numbers were combined and we could both offer services in both areas. So why introduce SGRT for paediatrics? So obviously you guys know the benefits of SGRT after this week. It facilitates tattoo-less radiotherapy, which is one of our main goals in our centre. It's reducing overall trauma, not only for the patients, but also for the families, and also for the staff. Trying to tattoo a child, particularly awake, is absolutely horrendous, and I can vouch for that. But also it's not just like the short-term trauma of upsetting the child and causing them the pain, it's the longer term for the families when it's a reminder when they look at those skin marks and think about what treatment they've been through. So as a centre, we actually already use open face masks, usually 3-point for our brain patients, but as you can see on the table, we had a little look back at some of our brain patients and we were re-imaging them quite a few times per fraction. That tended to be due to rotation issues, and I'll go on to talk about those a little bit more in the next few slides. So what we did from thinking about SGRT being a positive for our paediatric patients is an audit to start with. So we compared Align RT to our 3D cone beam function, so we use XVI. So we compared the translations and rotations from both systems, and we looked at 4 body patients and 4 brain patients. We used standard setups to start with, so for the body patients we tattooed them, and for the brain we would just use our open face mask with the reference points. So don't be alarmed by the amount of numbers. So this is just a very small snapshot of one patient and the data that we were trying to record all at one time. This is typed up, but we actually did it by hand whilst the patient was on the bed. So if you think about the time pressures and things, it was quite stressful, but we managed to get there.
So results for the brain patients that we were seeing is that, so this graph on the right is the individual data points for some of our brain patients, and it's comparing the difference between Align RT and our 3D cone beam. As you can see, for the vert, lat and long, it matches really well. For the pitch, roll and yaw, there is a bit more of a difference. We weren't really surprised to see this because we know that our paediatric patients are on a lot of steroids and they do suffer with significant swelling. I think if we repeated this phase 1 part of our audit now with how we've amended the ROIs, we probably wouldn't see such a difference. We're not going to do that, so we'll never know, but I think we probably would. And for the body, there's a greater spread over all axes, but actually the differences were less for the body. Again, we were kind of expecting this. We know with our paediatric body patients, especially the ones under GA, that they suffer from a lot of contour change. Paediatrics notoriously do not have much topography, so it is tricky to get the ROI right, and it's definitely been a learning curve, which Molly will speak about later. But our overall results between brain and body showed that actually we only had a millimetre or less translational and a degree or less rotational variation between cone beam CT and Align RT. So we decided that SGRT was safe to use as our primary setup tool.
So So some of the considerations from phase 1 of the audit, Sam's already mentioned a little bit about contour change. It was a limited sample size. Obviously, we don't get that many patients through, and we were comparing multiple different body sites to one another, so we just needed to take that into consideration. The risk of transcription error, again, we were taking down a lot of values all at a short amount of time, and with the ROIs, we were learning, and really we are still learning. One of the probably the biggest considerations that we noticed with the patients under GA, we were really struggling when they use a full LMA, so the laryngeal mask airway. So the tubing and all the wires and everything was really interrupting our deltas and causing quite a bit of havoc. And then the last consideration, so dignity, obviously it's just as relatable for adults, but normally for the younger patients as well, it's a really, really tricky topic. So especially when we're treating their pelvis, it was just trying to work around what was the optimal ROI to make sure that they also are kept dignified. But since phase 1, we've moved to phase 2 of our audit, and we are now using SGRT as our primary setup tool. So we are still tattooing our patients just because we've only got 2 systems at the moment. So if there was a fault, we wouldn't have a backup machine. But we are setting straight up to isocenter for our body patients using a line RT. And for the brain patients, we are pre-positioning them now, so before we apply the mask, and that really is improving our rotations before we scan them. We're now recording our re-imaging frequency and also the reason for re-images, so trying to keep an eye on contour change if there's anything we can try and do about that. And then probably one of the biggest highlights has been that we've been able to convince our GA team to use nasal cannulas, the nasal specs, instead of the full LMA. Obviously, we're safe to do so for the patients, but that's been a massive improvement in the camera occlusion.
Okay, so our first case study, this was a 7-year-old girl, and we were treating whole lungs for metastatic Ewing sarcoma. She was awake. She was initially part of the phase 1 audit, so we were just writing down the results that we saw on a line RT and comparing them to the results that we saw on the cone beam CT. After the first 2 days, we realised we could no longer ignore the yaw that a line RT was showing, and that our imaging was agreeing with. So the first couple of days, we did re-image her because we had to adjust her hips. So for those who aren't used to looking at images like this, the green is the cone beam CT and the pink is the planning scan. So you can see that her hips are too far over to her left. So it wasn't ethical to continue not using a line RT as our primary setup tool for this patient. And then when we did use a line RT, obviously it removed the yaw. So our second case study is a little boy who's come to us for treatment a couple of times. So he first came last year with DIPG, and he had 13 fractions. He started a week before our phase 1 audit started. He was really suffering with swelling from steroids. We were having to re-image him a lot during treatment. Bear in mind that these patients were already using open face masks because he was under GA. So when we started using a line RT, we were like, we have to move this boy onto a line RT machine and start using a line RT for him. We moved to daily imaging, and following the advice from Vision RT, we did pre-position without the mask on, and it significantly improved things for us. He then came back for treatment at the beginning of this year, and we went straight to the phase 2 part of the audit, and we're pre-positioning him. So some image examples. You can see from the first image that there's significant roll on that left-hand image, but actually when we used a line RT, the roll was eliminated. And then the second course of treatment, you can see how swollen his cheeks are. So we were really concerned when he came back. We thought we were going to have an awful lot of problems with him. And actually, it was brilliant. There was much less re-imaging. We only had to re-image him on his last fraction, and that was because of steroids and cheek swelling. Again, I think now, knowing what we know now, our ROI may have eliminated the need to re-image on that last fraction.
So these are some of the phase 2 audit examples, very quickly. So we had a 6-year-old boy who was under GA. We used the nasal specs on him, so avoided camera occlusion. He was our first paediatric that we went straight to isocenter on, completely ignoring tattoos, and we didn't have to re-image him once, which we think is a massive success. And then similarly, we had a patient with DIPG, again, GA with nasal specs, and she was a re-irradiation case as well who had had previous re-imaging, and once again, we didn't have to re-image once when she was on phase 2 of the audit.
So we think it's really important not just to stand here and talk to you about all the cases that have gone really well since we've used a line RT, and actually talk to you a little bit about when it didn't work so well. So this was her ROI. She was an extremely long volume. We were treating whole lungs and abdo. And you can see at the top of the image, there, the laser's not working very well, sorry, that her spine had moved off. Now, if you compare where the image had gone off to our ROI, you can see why that may have happened. She was on phase 2 part of the audit, so we were going straight to ISO, and we, for 3 fractures in a row, had to re-image to reposition her. The patient, unfortunately, was diagnosed with C. diff and flu after her first fraction, and she missed a week of treatment. So when she came back, she had significant contour change. She went from having nasal cannula, she was GA, having the nasal cannula to LMA. So a lot of things had changed from that first treatment fraction. We then changed our ROI to include a little T across the top. And so, yeah, we got there in the end. So I think the big message is even when it doesn't work, you can use your imaging to inform your ROI delineation, which is what we did with this case. And we also removed sections of the ROI that no longer worked so well now she had the LMA. It really evidenced how quickly staff can lose confidence with the system. We have all used tattoos for years and years and years. And the first thing people said to us was, well, let's just go back to tattoos. And we were like, well, tattoos at Ziffy and sides aren't going to help with your up at neck. Let's, and try using the imaging to inform our ROI. So I think it really highlights how important it is to bring staff along with you with the decisions that you're making and why you're choosing not to go back to tattoos and to continue to trust the Align RT system. Because cases like this, whilst they're tricky, in the long term do actually really, really help with staff confidence. So we've just treated our first craniospine. He's still on treatment at the moment. The way we plan our cranios is we have 3 separate ISA centres, so head, T-spine and L-spine. The clinicians are the main reason we haven't gone tattooless yet. And bringing in this new technique, there was no chance we were going to be allowed to use Align RT as our primary setup tool. But we did manage to convince them to let us use it as an aid to set up the patient. So 5-point immobilization mask. I think the talks today really highlight why we might be getting some of the issues that you'll see with this. And it's a tricky ROI. We need to know there's no pitch in yaw between head and L-spine. So what do we do with it? I mean, in hindsight, we probably should have spoken to Vision RT before we did it, but we didn't. So do you split it? Do you do it all in one? We actually did sort of 2 and 2 and 2. The doubters really struggled with 3 ROIs. They just couldn't see it all. So 2 ROIs together showed pitch, which we could correct for, which was great. We can't extend the ROI superiorly because of the 5-point mask. And the image showed yaw at the upper T-spine. So I think with this case study, as well as the previous girl that we showed you where we put the T across the top with the ROI, actually, that's really good evidence to suggest that we maybe shouldn't be using 5-point masks anymore and that we should either be going to 3-point and faceless or no mask at all eventually. Key issue is something like this, though, is patient dignity. How do you get a 14-year-old on the boy on the bed and say, we just need you to take all your clothes off? So that's just not going to happen. So it is definitely, I think especially with the paediatric patients, a real key issue that needs thinking about. We didn't really have any major translation and rotational issues, though. So you can see the middle image at the top. There is just very slight yaw on the spine. It's not dramatic. It didn't cause problems with our treatment, but we can all see now why that's happened. We didn't have an ROI in that area. You can also see, when we set up the patient, because we were using tattoos and ISO moves, the delta for the vert was reading at 1 centimetre. We were like, why is it reading at 1 centimetre? This is bizarre. But if you look at the bottom right-hand image there, he has so much gas. He was bulking up for treatment. He told us he was bulking up for treatment because he thought he was going to feel sick and lose loads of weight. So actually, that's why we had the big height move. He'd put on weight and he had a lot of gas. This was consistent for the second day as well. So we just did a this in future reference capture, which resolved that issue. But otherwise, Align RT and our cone beam CT matched really well.
So just a little bit about the learning that we've done about our ROIs. So obviously Sam, as a super user, it's been great to get trained by her and have like a small cohort of staff that are trained to do these just for consistency. This was our first patient that we tried. So we were avoiding her right-hand side because she's got a line and wiggly bags, which for paediatrics can be really tricky to avoid. And we did have quite a few issues with her images. You can see we've probably gone a little bit too inferior just across her ribs, probably getting a little bit of breathing and motion in there. So when we treated a similar area, we moved on to something a little bit different. So we still went quite thick across the top, but we brought it a little bit lower across her pelvis just to avoid that breathing motion and over her hips for a bit more topography. And then, as you saw before from one of our case studies, we've now learned that a T across the top can really help with the yaw that we've been struggling with. So we're going to try and go ahead with something like this in future. And then for the brain, so with the open face masks, I think with this one, again, one of our earlier patients, we went quite low down on the cheeks, and when they're really struggling with contour change from steroid use, that is causing us some issues with pitch. So we moved on to something like this. We brought it up ever so slightly on the cheeks, and also with our masks, we've got quite a limited field of view. So I've seen some of the vendors that have got more open sides, particularly for the pitch. So we've had to bring that down a little bit on the forehead. So again, it's just learning points for us in the future with our equipment.
So our impact so far, it's very difficult for us to compare pre-SGRT with post-SGRT. The patients pre-SGRT weren't daily imaging, so we can never make a direct comparison. However, we are already seeing a significant decrease in number of repeat imaging. So pre-Align RT, 14% of our brain patients had repeat imaging throughout their course of treatment. That is down to only 2% of treatment fractions now that have had repeat imaging, which I think we'll all agree is actually quite significant. Patients are therefore on the treatment couch for a shorter amount of time, which is what ultimately Molly's aim has been, is to reduce the trauma for these patients. So the less time that they're in the hospital, if we can remove LMA for nasal cannula, if we can reduce the amount of times we have to re-image, it's far less stressful for the patient, it's less invasive for the patient, and it's far less stressful for the families.
Just to add as well, it probably can reduce the amount of GA that we would need to use with open face masks. The children will be much more comfortable. So I think it'll make a big difference on them too. So yeah, our next steps, we've got grand plans, but I think in the shorter term, we are just looking at trying to go tattoo-less. It's trying to get our clinicians a bit more on board and the confidence of our staff members just to feel comfortable with that. A potential idea is having Tegaderm just as a backup whilst we've still only got the 2 machines with Align RT on. But I think something like even just doing this presentation with our colleagues will help, just to give them the evidence of the difference that we're already making, and probably get some feedback from the patients as well, just to see how they feel in their masks and how much shorter the time frame might be that they're on the bed. At the moment, it's anecdotal. We're telling you that it's shorter and it should be better for the patients, but we need to evidence that. So hopefully do a time audit and also do an immobilisation audit alongside that, just to see about how much more open we can get these face masks. Also, we would look to apply our learning to the adult cohort. So when we have another machine with SGRT capabilities, it'll be looking at whether adults, obviously based off of the evidence today, has been pretty helpful, whether adults can have open face masks too. And then, as Sam was saying before, particularly for our cranio patients, but in general as well, it's working with Vision RT further to see how we can improve our ROIs in future for a better treatment for the patient. It's a little bit of just our acknowledgements.
We definitely want to acknowledge Johnny Allred, who can't be here today, and he should be here today, but unfortunately can't. And he has done so much work with us, hasn't he, on this project? So, yeah, and definitely everyone at Birmingham who support us. And our lovely colleagues who are here to support us, and everyone at Vision RT as well, because you have been a great help. Thank you very much to everybody.